Today, I will talk on unstable total knee replacement. Primary total knee replacement is a highly successful orthopedic surgery. Most surgeries have shown excellent outcome following total knee replacement. Common cause of failure include infection, aseptic loosening, and instability. Following primary total knee replacement, incidence of symptomatic instability is nearly 1 to 2%. Instability after total knee replacement accounts for 10 to 22% of the revision procedures. Instability can manifest in various forms ranging from frank dislocation to vague non-specific complication according to the degree of instability. Instability can be classified as per time as early, late, plain, anteroposterior, mediolateral or rotational instability. Position of the knee, either it can be extensional or a flexion instability. Then how is total knee is stable? Factors responsible for stability of normal total knee replacement include proper alignment of the components, appropriate tension in the surrounding soft tissues, appropriate surgical technique. Joint lines should be perpendicular to the mechanical axis of the lower limb. This is accomplished by putting the tibial component exactly at right angle to the axis of the tibial shaft and putting the femoral component in 4 degrees valgus to the compensate for the offset created by femoral neck. Rectangular extension gap is necessary to prevent varus and valgus instability in extension. Bone cuts in appropriate alignment and a good soft tissue balancing is necessary to get a rectangular extension gap. Rectangular flexion gap. A rectangular flexion gap is important for stability in flexion. Rotation of the femoral component is the most important factor for rectangular flexion gap. Flexion and extension gap should be equal for stable knee. Appropriate tension in surrounding soft tissues is to be provided by insertion of a tibial insert of a proper thickness after creating equal rectangular flexion and extension gap. The presentation of unstable knee. It may vary from frank dislocation to mild vague symptoms according to the degree of instability present. Complete clinical and radiological evaluation is necessary to ascertain the cause and mechanism of instability. Clinical evaluation of the knee instability. In supine and weight-bearing positions, overall limb alignment is assessed. Angular alignment is noted in coronal and sagittal planes. Dynamic instability is noted by gait. Excessive laxity in anteroposterior and mediolateral plane is examined. Extensor mechanism examined with reference to the tracking and stability of the patella. Radiographic examination. You have to take a full-length AP X-ray, lateral and skyline view of the knee joint. In this X-ray, you can see mediolateral and anterior-posterior instability of the knee joint. Causes of instability. Incompetence of a major ligament structures because of the surgical damage to the collateral ligaments or incomplete release of the tight ligament or over release of the tight ligaments causes the ligament imbalance, or inappropriate ligament balancing will manifest appropriately as extension or flexion gap which is not rectangular, or post-operatively as a varus or valgus instability and deformity. MCL and PCL incompetence is most commonly encountered while incompetence of the LCL is less common. This may be result of unrecognized initial incompetence or surgical damage to the collaterals or incomplete release of the tight ligament or over release of the tight ligaments, or a chronic attritional failure can cause instability. In this figure you can see lax lateral collateral ligament or a tight lateral collateral ligament or tight PCL or a tight medial collateral ligament can cause instability in different planes. Not only the ligaments, the inappropriate bone cuts and malpositioning of the components also causes instability. Varus or valgus femoral or tibial cut or over section of the posterior femoral condyles or excessive posterior or anterior slope of the tibial cut or inappropriate rotation of the femoral component can cause instability. In this diagram, you can see inappropriate bone cuts or rotational problems can cause instability of the knee joint. Deficient extensor mechanism, particularly when coupled with the deficient PCL, can lead to posterior instability. Neuropathic joints or muscular imbalance around knee can also lead to instability. Improper design of implants was an important factor in the past, but not important nowadays. Instability in extension can be of two types, symmetric or asymmetric. Symmetric because of the thickness of the component is less than the extension gap. Cause of this can be excessive bone removal or abnormal lengthening of the ligament. Instability in extension asymmetric. Ligament asymmetry can be due to under or over release or surgical damage to the collateral ligaments or inappropriate bone cuts. Instability in flexion. Stable in extension but not in flexion. Undersized femoral component in AP plane. Flexion contractures. Lateral release from the distal femur impairs the lateral ligament support, which has been the cause of dislocation. A rotational position of the femoral component. Design of the prosthesis results from the inequality of flexion and extension gap can cause instability in flexion. Undersized femoral component in AP plane causes instability. Downsized femur affects only flexion gap that results in the instability in flexion. Rotational position of the femoral component causes instability in flexion. Genorecurvatum. There will be anterior subluxation of the tibia occurs in patients with rheumatoid arthritis and muscle paralysis. Anteroposterior instability. Compressive loading of the conforming forces of the femur and tibia in extension. AP instability rare in extension unless marked soft tissue laxity. As flexion increases, AP instability increases. Posterior subluxation can be problematic if there is a deficient extensor mechanism or deficient PCL. Balancing flexion and extension gap. It is necessary to achieve stability throughout range of motion. Testing the symmetry of gaps by lamina spreaders or spacer blocks. Excessive flexion gap is produced by over-resection of the posterior femoral condyles, undersized femoral component, anteriorly translated femoral component, or excessive posterior tibial slope. Techniques for equalizing flexion and extension gap. If it is tight in extension and tight in flexion, remove more tibia. If it is tight in extension, flexion is normal, remove more distal femur and posterior release. If it is normal in extension, tight in flexion, then downsize femur, increase posterior slope of tibia. It is normal in extension, loose in flexion, then larger femur or more femur can be resected and thicker tibial insert can be inserted. If it is loose in extension, normal in flexion, then distal augmentation of the femur or downsize the femur and use thicker tibial insert. If it is loose in flexion, loose in extension, use a larger tibial insert or should use a larger and distally augmented femur. Posterior cruciate ligament retention or substitution. Optimal tension in retained PCL is difficult. Late failure of PCL is common, producing instability months or years after total knee replacement. In PCL retaining optimal tension of the ligament improves the range of the flexion. PCL retaining or sectioning of the PCL produces a mean AP laxity of 10 mm at all positions. Joint line level. Good patellar tracking and collateral ligament symmetry throughout range of motion is very important. To prevent elevation of the joint line in knees with a fixed flexion deformity, full release of the posterior capsule and osteophyte removal before resecting additional femur to correct the deformity is necessary. Valgus instability. Incompetence of the collateral ligaments is the cause for the varus and valgus instability. Early is because of the failure to recognize a preoperative ligament incompetence or intraoperative collateral ligament damage or failure to achieve adequate mediolateral soft tissue balance or trauma in the immediate postoperative period causes varus valgus instability early in the postoperative period. Late is because difficult to analyze or maybe a multifactorial. Traumatic injury can lead to late collateral ligament rupture, malalignment and loosening, chronic attritional incompetence, failure of the constrained implant, Charcot joint and significant muscular weakness can cause late varus valgus instability. Prevention of valgus varus instability. Preoperative evaluation is very important. Whether the collateral ligaments are incompetent, preoperative valgus varus deformity is correctable, possibly to neutral. You have to see. Good intraoperative technique is very important. Evaluate the integrity of the collaterals, restore optimal alignment of the knee, approximately 5 to 8 degrees of valgus, achievement of symmetrical mediolateral soft tissue balancing, components to be oriented perpendicular to the mechanical axis of the femur and tibia, femoral intramedullary guide to produce 6 degrees of valgus in varus knee and 4 to 5 degrees in valgus knee. For rotational cuts are made centering in the epicondylar axis. For determining rotation of the femoral component, you can use white sides line, epicondylar axis and tibial shaft axis. Fixed varus deformity is because of the contracted pes anserenis tendons, superficial MCL, semimembranous insertion, medial capsule and deep MCL contracture causes fixed varus deformity. Correction of fixed varus deformity. Subperiosteal elevation of the medial capsule and superficial MCL is performed on proximal tibia and deep MCL from the tibial plateau is released. In flexed position, both cruciate ligaments are released and tibia is externally rotated. After bony cuts, remnants of the both cruciate ligaments and menisci are excised. Posterior condylar osteophytes removed. Largest spacer is inserted in flexion and in extension. Stability is checked. If required, further release done till achievement of the stability and rectangular flexion and extension gap. Schematic diagram, you can see medial soft tissue release. You have to release superficial medial collateral ligament subperiosteally and you have to remove osteophytes and medial pes anserenis ligaments. You have to release subperiosteally and you have to balance medial and lateral side. Fixed valgus deformity is because of the contracted iliotibial band, lateral collateral ligament, popliteus tendon and arcuate ligament and posterolateral complex. Correction of the fixed valgus deformity. Subperiosteal elevation of the capsule, deep MCL insertion of the proximal medial tibia, bone cuts and excision of the cruciate ligaments and menisci are performed. Largest spacer block that fits in flexion is fixed and stability assessed. Any instability, further ligament release done. In severe deformities, lateral side may be tight despite maximal release. Stripping of the lateral tibial condyle, including the insertion of the popliteal tendon, is done. In such situation, femorotibial constraints may be required. Flexion instability. Recognized most commonly in the setting of acute dislocation of the posterior stabilized knee. Incidence of dislocation is 1 to 2%, including the design of the cam and post mechanism and the use of large lateral soft tissue release in valgus is. Flexion instability. Increased flexion may be due to a mismatch in the flexion and extension gaps with the relative undersizing of the polyethylene. Two possible mechanisms are: first, in the slight flexion, a hamstring contracture or a posteriorly directed force may result in the cam riding up over the post if the polyethylene insert is relatively small versus the flexion gap. Second, extensive lateral side release has been performed to correct a valgus deformity. Instability can be prevented by appropriate bony cuts, tibial cuts should be perpendicular to the axis of the shaft of the tibia with 0 to 5 degrees of posterior slope. Distal femur should be cut using the major resection technique. It is advisable to counter resect the femur in a proper preoperatively lax knee. More than one reference line should be used while cutting posterior femoral condyles. Give appropriate external rotation to the femoral component. Prevention of the instability. Optimal soft tissue tensioning is very important. Tension should be symmetrical in medial and lateral soft tissues by properly balancing on medial and lateral aspects. Optimal tension retain PCL is achieved usually by recession. Knee instability can be treated by conservative method or surgical. Treatment is chosen as per presentation and severity of the symptoms. Conservative treatment is indicated in acute tibiofemoral dislocation, consists of close reduction, cast immobilization and intensive quadriceps rehabilitation. Mild chronic instabilities usually respond to muscle strengthening exercises. Operative treatment is indicated in a patient with gross instability or a chronic irreducible tibiofemoral dislocations who are unwilling to wear a brace full time, persistent pain associated with the instability, symptomatic progressive laxity of salvageable collateral ligament. Treatment should address the cause of instability. One should use the least constraints implants to handle the particular form of instability present. A posterior stabilized type of implant should be selected in case of an incompetent PCL. Mediolateral laxity by soft tissue balancing can be done if possible, or a constrained condylar implants can be placed. Instability after total knee replacement accounts for 10 to 22% of the revision procedures. All patients who present for evaluation of the instability require a thorough history to be taken and physical examination as well as appropriate imaging. Deep periprosthetic infection must be ruled out by laboratory testing and an aspiration of the knee must be carried out. The three main categories of the instability include flexion instability, extension instability and genorecurvatum. Most recently, the etiologies contributing to and surgical maneuvers required to correct flexion instability have been elucidated. While implant design and patient-related factors may certainly contribute to the etiology, surgical technique is also a significant factor in all forms of post-operative instability. If the first have to try the conservative method. If the patient is not responding or the instability is worsening, then you have to do a surgical procedure. In the surgical procedure, try to use least constrained implants as far as possible.